I think the problem has been noted by the Surgeon General and by others that so many kids with mental health problems are not identified. And even worse still, even among those that maybe someone knows they have a problem, they don't get into care. So how do we close that gap? So after the Surgeon General's a report in '99 and 2000, the Center for Mental Health Services and NIMH issued a contract to myself. I was then at Columbia University, and colleagues, national colleagues, who had the very best data sets in the country, so we could actually go in and look, how bad is the problem? Are kids under-recognized and underserved? And the reason we did that was because we knew that if they're under-recognized and underserved, we got to find a way to communicate with the public with messages that are sensible and easily understood by parents or pediatricians or teachers. So that was how the process really began. See, part of the problem for a parent is, if you look at what people have typically done when they've done public awareness or communication initiatives, they'll give a long list of all the symptoms that a psychiatrist might look for. And that's pretty confusing, because the symptoms always include things that kids often, or sometimes at least, have. What do I do with that? Yeah, my kid's inattentive, but every kid's inattentive. Yeah, my kid can be hyperactive sometimes, but is that really a problem? And so you have to understand, from the listener's point of view, from someone who's not a professional, they can't count up the symptoms and do all the intensive interviewing, and it doesn't make a lot of sense. It's not very helpful. So we realized that we needed to communicate better with families. We needed a tool. It was a communication tool. And we needed to distill these things down in a ways that parents would say, oh, that's what you mean. But you know, we doctors, we have our own favorite terms and our jargon. So what we did was, we started off with what we knew would really be important problems. And we used these big epidemiologic data sets to identify the big problems. But then we went to parents and families all across the country, and also teachers, youth, and pediatricians, primary care doctors, because we knew that they would be the ones to say, you know, they'd be the ones to, we got to make sure this is the right language for them, that they understand it. And so that was very helpful. That was a very useful step. So we had to get out of the mental health jargon and into the very best terms that would communicate with families, and to boil it down into one sentence so that they would understand and wouldn't be confused by all of our jargon. Our great hope is that we'll be able to find children who are overlooked and underserved, as the name of the paper is. And again, it's 3 out of 4. Now, what we did with this is we asked all of the major mental health organizations, both the professional associations and the primary care organizations, and all the family groups. And they all have a mission to educate their own people. And sometimes it's a public health mission to communicate to the public, to inform the public. So they all endorsed the toolkit. They all had a chance to weigh in and add items or correct the language or make sure it was consistent with their mission. So we're very excited and hopeful that organizations like the American Academy of Pediatrics, the Child Psychiatry, Academy of Child Psychiatry, or Family Practice, or the family advocacy organizations, or teachers associations, can take these, put them up on their website, make them available to their own members, and when they have opportunities for public information campaigns, they can use these very simple, very clear messages. If we get everybody on the same sheet of music, well, we think we might be able to make a dent in both reducing stigma and getting more kids help sooner, rather than waiting until things have gotten really bad or they end up in a juvenile justice facility or some other place.